Sure, I'd be glad to. First of all, let me thank Steve and his staff for being wonderful partners to the National Council and for your commitment to the Excellence Act. I also want to thank Kana and SAMHSA, who've been really champions all along, and how grateful we are and how grateful I think the people that are waiting to be served will be. So thank you. And of course to our board, which told us do whatever you have to do to make things better. And they meant it. We have an interesting board made up of members who are both mission-driven, but increasingly having to be very smart business people. And I think they understood what is needed in order to really raise the clinical floor. When I was thinking about today, and I'm going to try to do this very quickly, I talk quickly anyway. When I was thinking about today, we do a big conference every year, and our conference is coming up in March. And as I began to think about the plenary, I have a privilege of doing a plenary, I realized that my first plenary was 10 years ago in 2005. And so I want to read something that I had in that plenary in 2005, 10 years ago. It is difficult to adequately describe the challenges and barriers to quality care. Challenges that include the enormous complexity of services for individuals with mental illnesses and substance use disorders and criminal justice involvement, the cross-system needs of children and families, particularly those in the juvenile justice system, and the emotionally charged issues of public safety and individual choice. Yet each day, treatment organizations find practical solutions to complex problems. Trying to develop a staff that is competent in the delivery of practices based on evidence, they face a growing crisis in the recruitment and retention of staff at the salary level supported by our reimbursement structures. Expertise does not always come cheap. And I wanted to read that because when I went back and read the whole plenary, I thought, well, maybe I don't have to write another one. I'll just read the one I did in 2005, because I think those barriers remain in place. And I think the only big difference is we've actually increased the number of people with mental illnesses and addictions in jails and prisons in the last 10 years. So I think we have three questions. The first question is, what do we think will help? And increasingly, I think there's some consensus around that. So we all think single points of accountability with responsibility for caring for vulnerable populations, including those who are justice involved, is necessary. Who's going to be responsible? The other thing is integrated services, right? In many ways, we've taken services apart under the guise of choice, and we're really talking about putting them back together. We all like one-stop shopping. I think the other thing is we know now addictions can be chronic disorders, and we need a full continuum of services for the treatment of addictions, which is really the issue in many ways that face people and face us who want to connect with people coming out of jails and prisons. The other thing is we need a skilled staff. And it was very interesting talking and hearing about prospective payment, because in many ways behavioral health has been on the forefront of using community health workers. We call them peers. What we've not been able to do because of the lack of prospective payment is to have skilled clinicians, doctors and nurses, which you also need if you're going to take care of someone's not only psychiatric condition, but their medical condition. And we also need funds for technology. Someone in the audience who's a vendor was talking about technology. There are many technologies out there. What we know is consumers use them when they have support from real coaches and mentors. So we really need both. The second is, so what's the problem? We have parity in the ACA. How come we're not able to do all these things? Well, one of the effects of parity in the ACA is that competition is now the engine of progress and reform. And I'm going to explain that very quickly. Government downloads their risk to managed care companies. Managed care companies are downloading risk to providers. And that's not a bad thing, because risk changes behavior. The only problem is the specialty sector is not equal. They are not hospitals. They're not insurance companies, where, by the way, we're seeing tremendous mergers. Every hospital is buying up the hospital next door, and they're doing it because it's competitive out there. The other thing we're seeing, because you need deep pockets to compete, is the entrance of private equity into treatment. I think 65% of all methadone clinics are owned by private equity now. So we're seeing a tremendous change. And in a world where healthcare is a commodity, specialty behavioral health suffers from reimbursement disconnected from cost, restricted access to capital, and continual cash flow problems. So what's the answer? The only answer really are CCBHCs. I don't see other help on the horizon. You know, we're having what I call trickle-down healthcare, which is the money that's left in big ACOs and big systems for direct services to people with serious mental illnesses and addictions will be less rather than more, and not because all the players are bad people, but because that's the way we're setting up these large systems. So I think what we have is an opportunity here. We thank Senator Stabenow, and we actually agree with her that in many ways this has been done under the radar, which may be the only way to get anything done today because of our politicized world. The other thing is I don't want to overpromise. We are talking about social determinants of health all morning, things that were very sobering and humbling to me. We will make incremental progress. You know, ideas need to be big, but progress is incremental. I think this is a step in the right direction.
Thank you.